Hi, my name is Dr. Eric Arzubi. I'm a child and adolescent psychiatrist, and I'm CEO of Frontier Psychiatry. Today, let's talk about something that can be a little bit difficult sometimes, and that is screening for suicide among youth, safety planning for those youth, and then also talking to parents. I'm going to go ahead and share my screen and go through a series of kind of points I want to review before we get into safety planning and talking to families. So here I go, and hopefully you can see that. I think you can. So let's go ahead and get started. So suicide, as we all know, is a significant public health problem for people of all ages, and this is especially true in places like Montana, Alaska, Wyoming, Idaho, the rural states, right? 15% of all suicide deaths in the U.S. occur among youth and young adults aged 10 to 24. It's a pretty big number. And suicide is the second leading cause of death in this age group. There's been a pretty big increase in suicides, over 50% over the last 2 decades, and a staggering 9% of all youth have attempted suicide in the last year. And overall, about 3 million adolescents have had serious thoughts of suicide in the past. There are health disparities between different populations, so American Indians and Alaska Native youth are the most significantly impacted, having the highest rates of suicides and suicide attempts. There's also been a pretty sharp increase in suicides among non-Hispanic Black youth over 20 years, so that's an 87% jump. And as many of those of us who live in rural states can attest to, the rural youth suicide rates are pretty high, and they can be 50% higher than those among urban counterparts. Youth who are homeless are twice as likely to consider suicide and 3 times as likely to attempt it. And many of us know that LGBTQI plus youth face especially high risk, and even more so among those who have housing instability. And the other kind of staggering statistic is that young Black children under 12 are twice as likely to die by suicide compared to white children. So, yeah, suicide happens even among kids 12 and younger. So, as in anything, when we're thinking about mental health in children, you got to think about both risk factors and protective factors, right? And it's always an interplay between the risk factors and protective factors. And taking even a further step back, right, you're always talking about a combination of genetic risks and environmental risks, right? It's always genes and environment that combine for the health outcomes that we often see. So you certainly have these risks at the individual level, right? So you have adverse childhood experiences, right? That's toxic traumatic stress among youth that happens over the course of years and often includes a lot of different kinds of traumatic stress. And certainly inborn behavioral health challenges can contribute to that. At a relationship level, right, in schools, bullying is a huge risk factor, so that's something to always keep in mind and ask about. Social isolation, right, could be related to the bullying. Could be also related to one's temperament, being socially isolated, and also depends on geography, or having a recent loss of loved ones. And then at a community level, does the community overall have a history of trauma, maybe intergenerational trauma, and people living in a high-risk environment that could be in a community where there are very few economic and financial opportunities, it's not safe, and among other things that can contribute to feeling unsafe in a particular environment. And then at a societal level, which is also what we're seeing, right? Every 10 to 20 years now, the Surgeon General is reporting that we have a mental health crisis that doesn't seem to end, right? So here we are talking about this. So when talking to youth, again, of all ages, some of the things to think about are kind of the warning signs that might suggest there's imminent risk. One could be talking about wanting to die or kill oneself, right? Pretty obvious one, but one to pay attention to. A history of self-harming behaviors, having impulsive aggression, giving away valued possessions as if preparing to be gone for a long time, and then changes in behavior that make people worry. Mom, dad, loved ones, people in the family might start worrying. So if you take a look at the screening guidelines for suicide risk from the American Academy of Pediatrics, here's what it calls for. So youth ages 12 and above should be universally screened for suicide. Youth ages 8 to 11, screening when clinically indicated, again, maybe seeing some of the warning signs we discussed above. And then youth under age 8, assess only if the warning signs are present. Again, kids aged below 8 are, again, less likely to complete suicide. It happens, but really the screening should take place only if there's some obvious and overt signs that either come from the child or from the adults in their lives. So, contrary to some beliefs, I don't even know if it's really popular belief anymore, but asking about suicide does not cause suicide. People worry about that. I think that's mostly our own anxiety rather than reality. So again, you ask about suicide, it's not going to make people more suicidal. So asking about suicide does not put ideas in people's heads. And the best practice is to ask directly using validated tools. And so what are some of these tools? There's the Columbia Suicide Severity Rating Scale, the triage version, that's also known as the CSSRS. There's the PHQ-9, the adolescent version, which includes questions about self-harm and suicide. There's the ASQ, which is the Ask Suicide Screening questions. And then there's the Patient Safety Screener, also known as the PSS-3. So ideally, you can integrate this into the regular workflow. Again, we all have a lot of questions to ask, a lot of things to screen for. I encourage you, again, it's best practice to screen for suicide, and ways you can do it. And I'm sure a lot of you have thought about this already, but try to incorporate it into your regular workflow and the EHR systems. You can have your team administer these questionnaires, including a nurse or medical assistant. These questions can be asked verbally, on paper, or electronically. So it really doesn't matter how it's asked as long as you're really screening and giving youth time to sit with these questions and answer them. Try to screen without the parent or caregiver there. As you can imagine, a lot of youth just aren't as forthcoming or as honest when there's a caregiver, a mom, a dad, a loved one around. Give them that space to be able to answer the question honestly. And if you're working with a youth who does not speak English, use a trained interpreter for patients who are struggling with English as a first language. So screening more than once a month doesn't make sense. And really, if there's no kind of history of suicide attempts, try to screen at least once a year. So again, somewhere between 1 and 12 times a year. More than monthly doesn't make a lot of sense. And again, waiting more than a year, not recommended. So there's it's important once somebody screens positive for a suicide risk, it's important to kind of make sure you're ready to follow up by for example, using QPR, which suggests question, persuade, and refer as a follow-up method to someone who screens positive for suicide risk. Create a non-judgmental, supportive environment. And so what I mean by that is we as adults, as clinical professionals, but also as parents, need to try to avoid judging and reacting as much as possible when this comes up with youth. So, for example, I've had situations where parents will say to a child, let's say a 13-year-old says to a mom, I'm thinking about killing myself. I've heard of moms really reacting pretty loudly and because of the anxiety and saying, why are you going to kill yourself? You have everything you need. Stop talking like that. Or I'm going to take you to the hospital. And our own inability to kind of regulate our own emotion can make things more difficult. So again, reacting and responding in a way that's non-judgmental, as even-keeled as possible, is going to really help us draw out more information. So if somebody responds with an answer that suggests there's suicide risk, take a deep breath and ask some more questions. Tell me more about that. Wow, you must be really upset if you're feeling this way. What's going on? Rather than jumping right away to react to that suicide statement. And again, we always want to take these statements seriously, but we want to do so in a way that we're responding with equanimity, with calmness, and curiosity, because sometimes expressing suicidal thoughts is also a way to start a conversation when a youth does that. So keep that in mind. And again, if we shut down the conversation right away, that youth is less likely to talk about suicide or self-harming concerns in the future. So again, we just mentioned the non-judgmental, supportive environment. Try to communicate effectively in a way that's calm, supportive, psychologically safe. And then assessing the level of risk and the need for an intervention. So again, it goes back to asking some of those additional questions. You sound upset. You must be really upset if you're thinking about this. What's going on? And then there are going to be some more structured questions. And in fact, let me turn to some of those more structured questions right now. Let me see. I have them listed over here. I'm going to go ahead. So, for example, here's 5 questions that can be very effective when somebody answers in a way that raises some concern. Well, let me do this way. For example, you could ask, in the past few weeks, have you wished you were dead? Right? So what you're doing is you're starting off at a more passive level and opening up the conversation in a way, hopefully, that feels more safe. Right? Because by asking that question, you're assessing passive suicidal ideation, which often precedes active thoughts. You can help identify some early warning signs. And these passive wishes are there in 80% of adolescents who later do attempt suicide. So you're asking a good question. You're using language that's not that threatening. And again, this kind of question is easier to answer and less likely to get pushback. The next question, so there are 5 questions I'm going over. The next question you can ask is, in the past few weeks, have you been having thoughts about killing yourself? Right? So now you're starting to more directly assess for active suicidal ideation. Again, asking about this does not cause suicidal thoughts or suicidal acts. This question is present in all validated screening tools. Up to 80% of youth who attempt suicide end up giving clear verbal warnings, so you're making room for that. And again, this kind of question needs to be asked in a matter-of-fact, non-judgmental way. And this is really the core of the suicidal risk assessment. The next question you can ask is, in the past few weeks, have you felt that you or your family would be better off if you were dead? Sorry. That helps you understand if that youth feels like they're a burden on their family. Helps identify certain feelings around suicidal behavior. And it starts to really tease apart the people that maybe have these passive thoughts that later turn into real ideation. And then again, it can help open the door to understanding the motivation behind suicide. Next, it's important to ask, have you ever tried to kill yourself? But also ask, have you ever hurt yourself on purpose? Right? Because by assessing past suicidal behavior, that's a strong predictor for what will happen in the future. And if there has been a previous suicide attempt, the risk of future attempts goes up by 30 to 40 times. So really important question. And it's critical because a lot of youth won't spontaneously tell you, oh yeah, by the way, I tried killing myself in the past. So really ask about this. Up to a third of adolescents who die by suicide have attempted in the past. And this question really helps identify those high-risk patients who might require more intensive intervention regardless of their current ideation, because again, they're naturally at a higher risk. And then it can also inform safety planning and strategies for managing risk. And then finally, the question of what's happening right now. Are you having thoughts of killing yourself right now? Right? So you ask that when the previous questions have been answered in the affirmative, then you can ask, what about right now? And it helps you understand the difference between patients who need urgent intervention versus really a lot of kids who simply need an appropriate outpatient referral. It's important to help triage at this moment, and answering this question in the affirmative obviously raises the stakes and increases the risk. And your practice should have workflows built around when somebody answers in the affirmative here. But really, it's a pretty basic workflow. At this point, if somebody answers they're having thoughts of killing themselves right now, and they can identify a plan, at that point, really, you're talking about a crisis situation where you probably want to refer to a higher level of care. There are also questions you can ask parents. For example, have you noticed any changes in your child's mood or behavior recently? And again, I would encourage you to ask these questions with the youth not present. Next, has your child talked about death, dying, or not wanting to be alive? Does your child have access to potentially lethal means at home, like firearms, medications, other things? Has anyone in your family attempted or died by suicide? Again, in some ways, when it comes to suicide, past behaviors can be predictive of what happens in the future. And then asking, are there any stressors at home or school that might be affecting your child? That's really important because a lot of times the kind of current stressors or any major events in the present tend to be what tip people over into thinking about suicide. Like, for example, a really severe bullying episode, a breakup, failing a test, things like that can be pretty indicative of risk. Next, safety planning. Let's talk about safety planning. I'm going to share the screen for a safety plan here. Safety planning can be really powerful. It's powerful for a couple different reasons. First, it's effective. The research shows that safety planning is actually effective and works in reducing the risk for suicide, number one. Number two, hopefully it gives you and your staff the comfort of knowing you're doing something that's effective, right? Because the last thing we want to feel is sort of ineffective and panicking that we don't know what to do. So let's talk about safety planning. Let me increase the size of this. So safety planning is based on the concepts of cognitive behavioral therapy. And, I really encourage you to go to childmind.org, look up the safety plan and print it out. And either you or a staff member, work with a child to fill this out. So these are the steps. Pretty straightforward, actually. So question number one is, what are the triggers and warning signs that tell me when to use my plan? This helps the youth understand what are early warning signs. What are sort of the internal or external signs that things are about to get worse in terms of mood, behaviors, right? So here you see it includes thoughts, feelings, behaviors, or experiences that have been or could become dangerous. And some examples can be feeling tense, thoughts of dying, but everybody's different. Everybody's individual in the way they identify those thoughts or feelings. Number two, what are warning signs that others can see that show them that I need help? Right, so here's some examples. Others might see I have a scared face, or I'm clenching my fists, or I start yelling, right? These are things that loved ones, people close to them, can identify. But again, it teaches the youth to think about what others might be seeing, and that's important too. This next one is critical and important and should not be missed. What are three reasons for living, three things that you look forward to? So, for example, being with family or friends or pets, life goals, a sport, a movie, it could be anything. But it's important to try and help the youth identify three things that they look forward to that give them a continued reason for living. And this really brings that point home, the next question, which is the one thing that is most important to me and worth living for is, and you'll get all sorts of answers, but the important thing is that you get an answer. Next, coping strategies. What are coping strategies that I can do on my own to safely feel better? And here you'll see it explains further. Things that take my mind off problems, like relaxation skills, listening to calming music. Some people may want to listen to loud music. That's not calming. It doesn't matter. Going for a walk, going for a run. So again, these are coping strategies that someone can do on their own to safely feel better. Next question. What are coping statements that you can tell yourself? In other words, positive self-talk. And this, again, you're teaching the youth skills as they go through this. And positive self-talk could be, I am a good student. My pet loves me. I love my family. My family loves me. My favorite teacher always asks about me. It could be anything, but what are coping statements? Positive self-talk. Next, what are people, places, or activities that provide distraction? And that could be something like, going outside, sitting by the river. It could be going to the mall. It could be going to Barnes and Noble and sitting and looking at books. Or it could be a certain person that they need connecting with. So again, what are people, places, and activities that provide distraction? Next, how do you make your environment safe? What are the ways, and I'll read from here, what are the ways to reduce the risk of harm in places that I spend the most time with the help of designated responsible family member, friend, or agency? So for example, getting help to prevent access to sharp objects, weapons, medications, or illegal substances. So again, working with someone else, a loved one, in the place where the youth spends the most time to really get rid of things that are high risk or can be tempting for self-harm. And then next, you continue to build up their agency and their ability to find support. Write down the names of 3 people that you can call when you need help and in order to feel safe. So it could be parents, grandparents, or a trusted adult. And then what are professionals or agencies that you can call to help for help and to feel safe? Here you write the names, the phone numbers, along with emergency rooms and so forth. And so again, this going through and filling out this form is an intervention. It's a CBT-based intervention because you're asking about the connection between thoughts, feelings, and behaviors, which is what CBT is all about. And so this intervention is powerful. It's been shown to be effective and really allows you and your patient to process what's going on at this moment. And it gives them a tool. And again, what you should do is keep a copy for yourself and give the original to your patient. And that's a tool that they can use when they're struggling and when they're feeling a lot of distress. All right, let's keep going. So we talked about safety planning, and also some of the safety planning included, right, some safety counseling around lethal means. So, right, safe storage of guns, other weapons, discussing access to those firearms, medications, and other means, creating protective environments, and teaching coping and problem-solving skills. So that's what we did with safety planning. Next, right, we want to make sure we're engaging families and caregivers, right, building up a support system that's safe, supportive, and loving around the child, right? So we just talked about some of the questions that we can ask parents, right? So educating families about the warning signs, involving the families in safety planning, make sure that the parents get a copy of the safety plan as well, as long as the youth is willing and able to do that. That's another tool for parents as well. So in the middle of a distressing situation, people don't panic, and they can actually give this tool back to the child. We talked a little bit about supporting families with youth experiencing suicidal thoughts. Again, we should all be taking these statements seriously, but again, I encourage you to tell parents and caregivers to try and avoid overreacting when a child expresses sort of a scary thought. Instead, ask about that thought. Be curious about that thought. Ask further. You must feel awful to feel this way. What's happening? And be curious and pursue that conversation without judgment. Give parents and caregivers resources, and obviously this is something we hope to avoid, is the need for post-intervention, which means supporting families after a suicide loss. That'll be for another talk, but for now, just important to keep in mind. So, building partnerships and referral networks, right? So, the need to make sure that you have either a psychiatric practice or a group of therapists that you can turn to for your patients. Making sure that your practice is connected to local and state suicide prevention coalitions. There's NAMI, there's Mental Health America, there's several kind of advocacy groups that have lots of tools, awareness campaigns that can be helpful. There's the 988 Suicide and Crisis Lifeline. Don't forget about the crisis text line too. This is where anyone can text 741-741 and start an exchange via text with another person who's been trained to respond. And making sure to work with schools and other youth-serving organizations to make sure that everybody's on the same page. So what do you want to do? You want to address any barriers you might see in your pediatric practice. Are you asking these questions? Are you asking them in a way that's psychologically safe, non-judgmental? You're being curious, doing it without parents or caregivers present? Are you able to kind of integrate the screening process and the intervention process into your workflow? Do you have the ability to provide appropriate follow-up, either within or outside of your practice? Is your clinic a supportive environment? In other words, has everybody in your clinic been trained to have these conversations in a calm way, right? So if a mom calls, medical assistant picks up, starts talking that their child is suicidal, you don't necessarily want you don't always want the first thing to be really panic in anyone's voice. Is you want to start asking some questions with curiosity, non-judgmental, and provide resources. And again, by doing all these things, we're able to overcome stigma and promote help-seeking behaviors, which is what we want. So, resources for pediatricians, right? The AAP has lots of resources. SAMHSA's Suicide Prevention Branch has lots of resources. There's the Suicide Prevention Resource Center, the American Foundation for Suicide Prevention, have chapters in, I think, every state. And like I said, they're local and state suicide prevention coalitions. So, well, if we were live, I'd have a Q&A session, but we're not. So with that, I hope that this was a useful video, was comprehensive in going over the ways in which we can think about suicide risk among youth, how to screen for it, what to do next, to again stay calm, stay curious, and stay non-judgmental. And that way, everybody has a kind of a clear head to be able to think about next steps. And by all means, please, I encourage you, use the safety planning tool. It's a powerful tool. It works, and it's worth it. With that, we'll call this the end of the video. Again, my name is Dr. Eric Arzubi. I'm a board-certified child and adolescent psychiatrist and CEO of Frontier Psychiatry. Until next time.